what would be the dose of thrombolysis?
100 milligram of RTPA over 2 hours.
Yeah, so the dose is actually 100 milligrams of RTPA over 2 hours. But then you must understand it is 2 hours, it's not 1 hour. And then you give 10 milligrams, initially, and then you give it over the next 2 hours. Now it is going to take 2 hours before which we are able to thrombolize these particular patients. So that's why the dose per se is not very clear. So in the event that what we know now is 100 is equal to 50 milligrams, which is called as half dose thrombolysis, which is equivalent to the full dose thrombolysis. So you don't need to give 100 milligrams, you can give 50 milligrams also. Are you understanding? You can still give even 50 milligrams and you can escape with all these things. Okay, even 50 milligrams is enough per se. In fact, there are studies that have said 25 milligrams, ultra low dose TPA also will probably be effective in these cases. So 25 milligrams of thrombolytic agent also could be actually beneficial than no thrombolysis in those patients in which you want to thrombolize pulmonary embolisms. You understand? Because if you look at it, we don't want to thrombolize the whole body. We want to thrombolize only a small segment of the clot. Now, a small segment of a clot will not require very high doses. You understand? For example, you have seen catheter-directed thrombolysis done in patients that are admitted into the ICU. Okay. Now, when you see catheter-directed thrombolysis, how much thrombolysis are thrombolytic agent? What is the dose that they are giving there?
Utilized 2 ml. Okay. 2 ml per hour.
It's 1 milligram an hour. Okay, it's 1 milligram. That is the dose that they are giving. So in a whole day, only 24 milligrams is going. Are you understanding? In the whole day, only 24 milligrams are going. So if catheter-directed thrombolysis is working at such a low amount, logically you must think that even in pulmonary embolism, we may not really require such a large dose. You understand? Logically, it's clear that you probably may. It's kind of going towards clarity, saying that you may benefit even with a smaller dose of thrombolytic agent than no dose, than absolutely no dose. You understand? Huh? So when she did talk about vena cava filters, there is now at this moment hardly any role for vena cava filter. The only place where you use it, what is a vena cava filter? Anybody? What is a vena cava filter? How does it look? What is it all about? When do you think you'll use it, Ashok?
Using lower limb DVT to prevent the clot to be dislodged in pulmonary circulation, and it will place in.
So that is not the indication. The indication is if you cannot anticoagulate. In spite of anticoagulation, if there is a recurrence of pulmonary embolism, that is the indication for having a vena cava filter. That means you have given topmost anticoagulation, guideline directed therapy you have done, and in spite of that, if the patient develops a pulmonary embolism, then that is a candidate that actually warrants placement of an IVC filter. You understand? An IVC filter does not mean you don't give anticoagulation. You will still need to give anticoagulation. Why? Because there is a filter in place now. There is another thrombogenic agent. Are you understanding? So, not only does a filter cause problems, which includes vessel dissection, which includes migration, which includes clot formation, which includes DVT because of the fact that the venous return is actually reducing because of the presence of an umbrella or a vena cava filter. There are other problems that are coming with it. So the indications for a vena cava filter are only and only if the patient has been on full therapeutic anticoagulation, and in spite of full therapeutic anticoagulation, patient develops a pulmonary embolism. So there are really no major indications as of now for vena cava filters. Remember this. Even after putting a vena cava filter, after a couple of months you have to take it out. It can't just remain inside the body. So it has to be even retrieved after a couple of months. Okay, it just can't be remaining inside the body. It has to be retrieved after a couple of months. Clear on this? And the risk is very low. Now, say for example, now you have thrombolized your patient. Okay, you have thrombolized your patient and the patient now bleeds into the brain. What is the next thing you are going to do? So usually what you are doing, you are actually giving upfront heparin, and at the same time you are thrombolizing your patient, or you might give thrombolytic agent and then start upfront heparin. This is what you are doing, isn't it? In patients of pulmonary embolism, because you want to anticoagulate them simultaneously, unlike acute ischemic stroke patients where you will give the thrombolytic agent, wait for 24 hours, ascertain that there is no IC hemorrhage, look at the bleeding tendencies and then give heparin, isn't it? That's the difference between acute ischemic stroke and and pulmonary embolism related or myocardial infarction related thrombolytic agents, where you directly upfront give them Clexane. So now you are faced with an important problem, and the problem is about bleeding. There is a possibility of the patient bleeding, okay, the risk of which is somewhere around 2.4%. The risk is so when you are explaining to your patient, you have to tell them about the risk of bleeding, which can be anywhere between 2.4 to 5%. So when you're taking consent, you're supposed to tell them that there is a chance of bleeding, and the bleeding risk is around 4 to 6. In when you look at acute ischemic stroke, the bleeding is about 6%, whereas otherwise it is 2.4%. Okay, so you have to talk about that bleeding risk that is there. Without talking about bleeding risk, you should never go ahead and thrombolize your patient. And that is the reason that you should very carefully look at the fibrinolytic checklist. So every time you have a patient that is going to go for a thrombolysis, it is important to pull out the fibrinolytic checklist from inside. You know there's a fibrinolytic checklist inside the ICU. Okay, take the fibrinolytic checklist out, it is there in a file, and then start marking it out. So it has to be quickly done. That there is no ischemic stroke in the last 3 months, there has been no hemorrhage in the past, there has been no anticoagulation with an INR of more than 1.7. The blood pressures are almost less than 180/110. All these things you have to be knowing from. That's why you can't remember all of these things. So you normally need a checklist to quickly sign off. Okay, this has not occurred, this has not occurred, this has not occurred, and now there is no contraindication to thrombolysis. Then you thrombolize. God forbid you thrombolize and the patient bled. What is the next step? What is the next step? So what do you feel we should do the next step? The patient has bled into the brain. Now why is the patient bleeding in the first place? How is this thrombolytic agent working? How is the thrombolytic agent working? How is antiplase working? What is antiplase? So what is it actually made of? It is a human DNA recombinant. It's a recombinant kind of substance that is made, right? Tissue plasminogen activator. So how does it work?
Plasminogen activator breaks down the plasminogen.
So yeah, you're right. Plasminogen, TPA will convert the plasminogen to plasmin, and plasmin will ask on fibrin. Will ask on fibrin to destroy the clot. You understand? So it's specific to fibrin. It is specific to fibrin. But at the meantime, what it also does, TPA is actually it works on the fibrin and actually destroys the GP2A glycoproteins that are there on the platelets. So that also it works on. Now when it breaks down the fibrin, it also converts to fibrin degradation products, which has its own anticoagulant. It has its own bleeding tendency, fibrinogen degradation products. Okay. First of all, what is the half-life of TPA? The half-life of TPA is not more than 4 minutes. It is only 4 minutes. The half-life of TPA is 4 minutes. However, the effect can last at least 4 or 5 times the half-life. So it can go up to 20 minutes to 40 minutes also, the effect of TPA. So once you are given TPA, there is a chance of bleeding immediately at 4 minutes, and it can be, and the effect can remain for more than 40 minutes too. Now that is not the only effect. As I just now told you, that when you are actually going to degrade the fibrin, there is also some activity on the platelet receptors. So when there is an activity on the platelet receptors, even the platelets are not really functioning that well. And now you are coupling that with your heparin that is on. You are coupling that with the heparin that is on. So you have a problem here where the patient is bled. At the same time, the bleeding is because of TPA as well as because of heparin. Okay, and you have a clot on the background. This is a life-threatening bleed. You will not go and try to reverse the bleeding that is there inside the nose, a bleeding that is there inside the mouth, a hematuria. These are the things that I will not going to do anything for. But which are the bleeds I'm going to tackle? I'm going to tackle massive GI bleeds, which by definition is more than a gram drop of hemoglobin. Or I'm going to look at a massive IC bleed, IC hemorrhage. So these are the things that I want to look at immediately. And why do I want to look at this IC bleed so urgently and so fast? Because we know that every half an hour or to 1 hour, there is a 33% increase in the hemorrhage, increase the size of the hemorrhage, which can cause very poor outcomes. So that is the reason that if you have IC hemorrhage, I can't say, oh, isko IC hemorrhage ho gaya, chalo mannitol do. It doesn't work like that. Okay, if the patient gets IC hemorrhage, there is a very high chance of the hematoma increasing by more than 33%, which will cause pressure effects on the brain, and the patient will die because of coning. Okay, and that is the reason that whatever activity you want to do, you have to do it quickly. That means you want to reverse the thrombolytic agent as quickly as possible. Right? You have to reverse it. So how do you reverse this? How do you get around this problem? First though, what is the pathophysiology? It is causing fibrinolysis. So I will want to use an antifibrinolytic agent. Which is the common antifibrinolytic agent that you know? Tranexamic acid. Simple, no? The antifibrinolytic agent that you know usually is tranexamic acid. So how do you give the tranexamic acid? You give a gram of tranexamic acid and then give 1 gram over the next 1 hour. 1 gram start or 1 gram over 1 hour. This is very different from what you do for massive hemorrhage and trauma. What do you do in massive hemorrhage and trauma?
1 gram stack with 1 gram in 8 hours.
Over 8 hours. So in massive hemorrhage and trauma, it's 1 gram stack, 500 milligrams over 8 hours. Okay, that is the combination you give for trauma. Okay, for example, you have an ICD put inside, you give a gram, that's a trauma, it's a 500 milligrams over 8 hours. That is what you do. Don't give it fast, doesn't make sense. Okay, it doesn't make sense. So 1 gram stack and 500 milligrams over 8 hours is what you normally give, but in this case, you probably want to give a gram followed by a gram over 1 hour. Okay, that's what you probably do with tranexamic acid. What else would you want to give in these cases? So what is happening here as a pathophysiology, what is happening? You have TPA that you have given. This TPA has converted plasminogen to plasmin. Plasmin has degraded the fibrinogen to fibrin, and fibrin is getting spoiled, right? Fibrin is getting out. So what is reducing here? What is reducing? Fibrinogen. What is reducing here is fibrinogen. The pathophysiology says very clearly that what is reducing here is fibrinogen. So what you need to do in these cases? You need to probably give fibrinogen. Okay, so immediately you are supposed to give fibrinogen because fibrin is degrading over here. Now, how much fibrinogen do you give? So normally, when what is the fibrinogen level you want to give? So immediately I'll do an INR, I'll do a PTT, I'll do a fibrinogen levels immediately. Okay. Now, with respect to that investigation, I'll decide what I want to do. So if I want to give fibrinogen, I want to keep the fibrinogen level above 200. Okay. Otherwise, in all other cases, I want to keep it at 150. At all other cases, I am going to keep it at 150. So if you notice what I am talking to you, in the brain, we are doing everything a little bit more. In the brain, we are doing a little bit more when you are looking at brain. Okay, so that is why if you want to increase fibrinogen, I will want to increase it above 200. 200, 250 is what I want to keep. 200, 250 and not 150 because normally we want to keep it at 150. 100 and above. 100 to 150. Now we want to keep it 200 to 250. So what is the drug you'd want to give in this case? What is the drug you'd want to give in this case? What is the medicine or what is the agent you want to give in this case? Cryoprecipitate. So there are fibrinogen now that is available. Injection fibrinogen is available which you can give directly. Injection fibrinogen which is very quick, very fast, expensive though. Okay, very quick, very fast, expensive though. But you probably the simplest option to give in the scenario is cryoprecipitate. That's why the moment he bleeds, you have to do simultaneously a lot of things: sending coagulation workup, looking at the neurology, doing an IC, CT scan, telling the blood bank, give me 10 cryoprecipitate. So how much cryoprecipitate you want to give usually? 10 and 10 raises the fibrinogen by. You should know this because without knowing that there is no point. You know how much does it raise by? How much does it raise? Anyone? Wild guess? Anyone? How much does it raise? How much does it raise? Anyone? Any wild guess? कितने raise होएगा? हाँ? 50. So it raises by 50. So what does this indicate? What does it indicate? If you get a fibrinogen level that is 50, then I cannot just give 10 cryoprecipitates. I need to give probably 30 cryoprecipitates. Are you understanding? The amount of cryoprecipitate you need to give will actually depend on the amount of fibrinogen that is there. Okay, so on an approximate level, 10 cryoprecipitates will cause the fibrinogen to go up by 50. Clear on this? Clear? Any doubts till now? Now you have given this patient heparin also, right? So you need to give us that also. Okay, so at this moment you are given tranexamic acid, you have given cryoprecipitate. The third thing for TPA you want to give because it works on the platelet receptors is you might benefit by giving platelets also. Okay, you might benefit by giving a couple of platelets also because of the fact that this TPA has got an effect on the platelet receptors also. Okay, the fibrinogen degradation products have got an effect on the platelets also. So I will probably give a few bags of platelets to 2 or 3 bags. I'm not very certain how much we should give. It's not very certain otherwise. So 2 or 3 bags of platelets also would be given in accordance with the TPA. But what I'm not clearly giving is FFP because I don't have a change in the INR, nor do I have a change in the PTT. Okay, as of now. Now, if you are on heparin, then what do you do? If you are on heparin, what do you do? I want to give protamine. So how much protamine do you give?
So 1 milligram per 100.
So it depends on what kind of heparin you are using. So if you are using heparin as a TDS dose, it will depend on the timing of heparin. Are you understanding? It will depend on timing. So if it's in the first 30 minutes, I would give 1 milligram of protamine to the units of heparin. If it's in the first 30 minutes, for example, I have given heparin at 8 a.m. in the morning, And 8:30 he has bled. Okay, so if he's bled at 8:30, then 30 minutes is the interval between giving heparin and this. We're not talking about infusion, we're talking of giving heparin bolus. Okay, give bolus. So at that time, how much would you want to give? 1 milligram per unit of per 100 units of heparin. So if I've given 30, if I give 3000 units of heparin, how much milligrams of protamine will I give? Clear? So if I have given 3000 units of heparin, I'll give 30. What if I have given 10,000 units of heparin? No, I will never give more than 50 milligrams. So I will never give more than 50 milligrams. Okay, the answer is I will never give more than 50 milligrams. So the maximum dose of protamine that you can give at any given moment is 50 milligrams. You're not supposed to give anything more than 50 milligrams because this is made from an animal source. There is a very high chance of hypotension, bradycardia, anaphylaxis and shock. Okay, it has to be given slowly over 15 minutes. It cannot be given quick, it has to be given slowly over 15 minutes. Clear? So protamine, if it is given in the first 30 minutes of heparin, I would give 1 milligram per 100 units of heparin. What if it is beyond 30 minutes? If it's beyond 30 minutes to 60 minutes, that's in the first 1 hour, I would want to give 0.5 milligrams of heparin, 0.5 milligrams of protamine per 100 units of heparin. And if it's gone beyond 1 hour to 120 minutes, I would want to give 0.3 milligrams. Okay, 0.3 milligrams. Clear on this? 0.3 milligrams. Anything beyond 120 minutes, anything beyond 120 minutes is 0.25 milligrams. Clear? Anything 0.25. So there are 4 doses that I have explained to you. The first dose is if you are within 30 minutes, you are going to give a milligram per 100 units of heparin. If I am beyond my 30 minutes and I am within 60 minutes, I probably want to give 0.5 milligrams. If it's 60 minutes to 120 minutes, I'd give 0.3 milligrams. And once I am beyond that 2 hours, it is 0.25 milligrams of protamine per 100 units of heparin. You have understood this? Any doubts till now? Any doubts? No. So now what happens if you are on an infusion? Now what do you do? If you are on an infusion, what do you do? Now this was about a patient on heparin with a bolus. Now what happens if you are on an infusion? Huh?
Last 60 minutes.
Last?
60 minutes.
Last 2 hours. So what you do is you take the last 2 hours dose. Okay, so you take the last 2 hours dose, find out how much units of heparin has gone inside and give 1 milligram per 100 units again. Okay, so if you are at let's take the example, if you are at 1000 units per hour, 1000 units per hour has been 3 hours. It's been 3 hours. What do you do then? So let's put it on the board. Just put it on the board. 3000 1000 units per hour. 1000 units per hour for 3 hours. Oh, how do you reverse this?
Total 30,000 units given in last 2 hours. 3,000, sorry. And
So say 1000 units per hour for 3 hours, right? So you are given a total of 3000 units because it's 3 hours. Now 3000 units last 2 hours is 2000 units. So 1 milligram in 1000 unit, 1 milligram in 100 unit. So it will be of 20 milligrams of protamine. Clear? Simple. So that's how you reverse heparin, and you'll repeat the PTT in say a couple of hours again, in say 30 minutes again. You repeat the PTT again in 30 minutes and then accordingly reverse it if the heparin effect still remains. So the next time you reverse it, you give half the dose. So you have done the reversal over here. Now 30 minutes later you have done a PTT. The PTT has come out to be still elevated. Okay, that means the heparin effect is still remaining. So what do? I give half this dose, 10 milligrams again. Okay, that's how you reverse heparin as an infusion. And that's why you reverse heparin as an infusion. That's why when a patient comes in from cardiac surgery, they don't tell you to give 50 milligrams or 100 milligrams. They 5 milligrams, 10 milligrams. That's how they tell you to give, because of the fact that they have already given some amount of reversal over there. They are still expecting some ACT to be elevated, PT to be elevated. That's why they are telling you to give some protamine. Clear? Clear? Now what happens if the patient is on LMWH? This is all about can you reverse LMWH? If the patient has been on heparin, like for example you are on enoxaparin, what do you do? If it's an enoxaparin, what do you do? Say for example today morning the patient came into the hospital you saw an IC bleed, you saw a patient to be ischemic pulmonary embolism, you have thrombolized this patient and started the patient on heparin given 0.6 ml. 0.6 milligrams, 60 milligrams of Clexane or enoxaparin you have given. Then what do you do? What is the next step? If you are on 60 milligrams of enoxaparin, what is the next step you will do?
Protamine.
How much protamine will you give? How much? What is your answer? How much will you give? Come on quickly. Anyone? Anyone? Do you reverse it or not? Can you reverse it or not?
Yes, you can reverse the protamine, but
Huh?
yes.
You can. So it's not like this. So if it is less than 8 hours, if it is less than 8 hours, if it is less than 8 hours, I would want to reverse it 1 milligram per milligram of enoxaparin. You understand? So if I'm on 60, if I've given 40 milligrams of enoxaparin, I will give 40 milligrams of protamine. If it is within 8 hours, okay, within 8 hours. So you should know the timings well. Okay, within 8 hours. If you are beyond 8 hours, it becomes 0.5 milligram per milligram of enoxaparin. That was per 100 units of heparin. This is per milligram of enoxaparin, right? And beyond 12 hours, it is doubtful whether it will probably reverse the heparin or not. Once you do this, you repeat the anti-10A levels if you have anti-10A levels to do that, or if there is significant bleeding still, you may want to repeat the dose of protamine just like how we are doing here. Okay, maybe 30 minutes later, you see whether the bleeding has stopped. If it has not stopped, because it's an instantaneously effect. If it doesn't stop, you probably give another half dose. Clear? Clear on this? Now what about the antiplatelets? For example, you have also given this patient a good dose of antiplatelets. What do you do with that? So you understand, we are in that complication where the patient has got an IC bleed, you have an antiplatelet agent you have also given. So what will you do with that? Sorry?
Platelet transfusion.
So question is, do we do that? How is antiplatelets, how are platelet plugs getting formed? Platelet plugs are getting formed with platelet coming, fibrin coming, joining together. So in short, if I increase my amount of fibrin, my plugs will form faster. So maybe I can increase my fibrinogen here. So that means I need to give an antifibrinolytic agent again. Okay. So as far as possible, if there is antiplatelets related bleeding that are occurring, I may want to give tranexamic acid. Why? Because it will prevent antifibrinolysis. Right? That is the first thing. Second thing, I want to keep my fibrinogen on the higher side because I will form those fibrin bridges much faster. So I'll do that. When it comes to platelets, each of these antiplatelets got a different action. So it all will depend on how reversible the antiplatelet agent is all about. Is it irreversible inhibition of of the platelets, or is it reversible inhibition of platelets? I mean, is the clopidogrel having reversible inhibition of platelet, or is it, when you say reversible inhibition, means what is happening? Clopidogrel is spoiling the platelet, coming out, and then going to another platelet, finishing spoiling the platelet, coming out. That is the meaning of reversible. You're understanding? Compared to Brilinta, which you give, it is irreversible. Are you understanding? So if it is a reversible inhibition, it is very easy. It is very difficult to actually reverse that agent because the coming platelets also will be reversed. Are you understanding? The interplatelets also be reversed. And there was one trial called as a patch trial where they actually gave platelets to patients who had IC bleed. It's called a patch trial if I'm not mistaken. There they gave platelet to these patients and they actually had worse prognosis. So as of now, it's not very certain whether you probably want to give antiplatelets, but maybe in those that are irreversible agents, these platelet transfusions might kind of work. How do you know this, that the platelets are inhibited or non-inhibited? What is the test required for that? Bleeding time, very difficult, very difficult to actually say when you are bleeding like this, like in TPA and all together, whether the platelets are causing a problem or whether something else. Bleeding time will be prolonged in anything here. It can be prolonged just because of the TPA, it can be prolonged because of anything. You understand? But how do you know that it is, bleeding time is a good test, but it is a broad test, it's not a specific test. Which is a specific test that you will probably use for figuring out platelet count, platelet is functioning, not functioning well. Which is the... TEG, not TEG also, because TEG, what TEG will do, TEG is more of a coagulation assay, Okay, what happens with TEG is that it will tell you, okay, you need there is a presence of DIC, there is a presence of fibrinolysis, but it won't tell you platelet deficiency or platelet function deficiency. So when a TEG is actually combined with something called as a platelet mapping, it's something called as a platelet mapping. Okay, then only we can actually figure out whether the platelets are dysfunctional or not. So there is something called platelet mapping. So when you're doing a platelet mapping, you'll know whether this is dysfunctional or not. Clear? Just a TEG will not tell you about platelet dysfunction per se. It might tell you about fibrinogen, it might tell you about plasma, it might tell you about lytic agents, but it may not tell you about platelet dysfunction. And that's why you need platelet mapping. So you cannot just do a TEG plus platelet mapping. That will give you an idea of the entire coagulation picture, entire hemolytic picture that is happening. Clear? Huh? So what have you understood at the end of thrombolysis? Thrombolysis is a difficult procedure. Okay, as a doctors, you must understand that you have to monitor these patients very closely. Why you have to monitor these patients very closely? Because there is a very high chance of patient going into bleeding, and that bleeding can be recognized only when you monitor them. There is no other way to do it. You have to monitor them. Okay, and clinical monitoring, that is how it is. And what you have also understood, that if he bleeds into the brain or bleeds anywhere, you have to act very quickly, because you cannot say, okay, give him cryopressure and come after 2 hours. It doesn't work like that, because the patient has to be given the cryopressure at that given moment, not delayed it after 1 or 2 hours. It doesn't make sense only. It doesn't make sense. After 2 hours, there is no effect. 40 minutes are done. You understand? It's the effect is barely for that time, and in that time all the damage is done. You want to prevent that damage. You want to prevent the damage. You want to prevent the damage. It's very essential that you are actually after on the phone. Give me the cryo, because cryo is something that will take time to go get in. You understanding? By that time, tranexamic acid, this, that, all that has to go inside. So what have you understood? It's a life-threatening emergency. We don't have much evidence with respect to thrombolytic bleeding. Whatever we know, we are trying to use our logic to ensure that there is no more further bleeding. Right? But at the end of the day, monitoring. At the end of monitoring is very, very important. Right? You can stop this.
So in such cases, imaging because